Welcome, everyone. My name is Sarah Mattis Marshall. I am Executive Director of the Virginia College of Emergency Physicians. And this afternoon, we are bringing you a town hall webinar to discuss the recent ACEP EM workforce study. With us tonight is VACEP President, Dr. Cameron Oderach. Cameron, welcome.
Thank you, Sarah. Thank you guys for taking the time to join us tonight and for caring about where we're going. The information that we got just 2-3 weeks ago from ACEP on this study has made a lot of waves through our community. And now we're coming together looking to try to solve what the data suggests is going to happen. And as we do that, we need everyone to participate and people to be involved in coming up with some of those solutions. So I'm excited that folks are chiming in. And for people who are watching afterwards, please send us your ideas. Please reach out to Sarah or myself and let us know what your thoughts are and how you think we can solve this.
I will also mention that we've received some questions ahead of time that we'll be answering tonight, but if you have other questions, you can send them via the Q&A function or the chat, and we will get to them later in the town hall. Joining us shortly is Dr. Bruce Lowe, past president of the Virginia College of Emergency Physicians. We'll let him get connected here. Right, Cameron, while Bruce is getting connected, what key points of the study would you like to point out?
So I think that there are a couple of things from the study that we really can highlight. I think, bottom line up front is that they're projecting for the first time in history that there's going to be an oversupply of emergency physicians in the next decade. I think we also have to understand that this study is based on a model. And so there's a lot of assumptions made in the model. And the other caveat to it is also that there's a lot of this data is pre-COVID. And so we don't know how that's going to affect things. We think that it highlighted some of these problems earlier than it might have otherwise been highlighted. But in the end, the study showed that the projected supply, assuming a 2% growth in residents, that 98% of those residents enter emergency medicine, and that there's a 3% attrition rate for current practicing emergency physicians, is that there would be an oversupply of about 59,000 physicians, and that the demand, if the visits per physician are constant, and there's a 20% rate seen by PAs and NPs, that the demand would be 49,600, which leaves us with a surplus of about 9,400 physicians. And so that's where all those numbers came from. And again, you can hear that there's a lot of assumptions in that, but I think in general, we saw a lot of these trends prior, and the data from the residents graduating now show how much harder it is to get a job. There's really two sides of the solutions that people have been talking about. There's the supply side and the demand side. The supply being the number of physicians coming out of residencies and staying, and the demand being the number of jobs available for emergency physicians. And so as we talk about different solutions that have been put out, they kind of have been grouped into the two different sides of things. In the webinar that was given by ACEP, and I hope you all have taken some time to look through at least the PDF of the slides, if not listen to it. And if you haven't, please go back and do that. But they cited some data that said that to reach a steady state, they would need to decrease the number of residents a year by about 1,100 residents for that supply side to be the whole answer. And so I think as we look at this, we're looking at a lot of combinations of different approaches, that there's not one thing that's going to find all of these numbers to make it where we don't have quite the surplus and we have emergency physicians not being able to work in emergency medicine. I think just breaking down some of the supply ideas, the big picture, there was, stemming the growth of emergency medicine residents and residency programs. There were a lot of ideas about how to decrease the number of programs out there, decreasing the number of residents per program, and then also raising the bar. So making sure that there's maybe some increased procedural requirements for graduation to really ensure that everyone coming out of all these residencies is trained for the work we do in the broad picture of it. There were a lot of interesting demand ideas also thrown out. And a lot of those talking about broadening the umbrella and expanding the emergency medicine practice and what that means. A lot of people talk about how anesthesia kind of embraced pain medicine and coming up with other opportunities for emergency physicians to practice maybe outside of a traditional emergency department. And then also expanding the reach and how can we support care in all geographies. And I think overall, what we really need to keep in mind is how we make sure that all of the patients in the emergency departments are receive care directed by an emergency physician, no matter where they are. I think, there are some concerns that some of this data may not be 100% reliable. I think, there is some assumptions made. Some of this data is pre-COVID, but I think some of these big picture ideas are issues that we've seen coming up for a while. And it's really an opportunity that we have to improve our specialty with regards to a lot of the scope of practice concerns, a lot of the residency training concerns, a lot of the practice model concerns that have been talked about for years. And this really gives us an opportunity for the emergency physicians as a whole to have these conversations and come up with solutions so that the specialty overall comes out being able to provide even better emergency care. And I think, really there's not just one magic bullet for this stuff. I think there's a lot of good ideas out there. And I think that that's really important. And that's why we're here, is to really be able to discuss all these ideas to generate what the best solution combination of things really looks like.
Thank you, Cameron. Some other members of our executive committee have joined us as panelists. I mentioned Dr. Bruce Lowe, past president of VACEP. We also have Dr. Todd Parker in the panel. He is our president-elect, and Dr. Scott Hickey, our immediate past president. For the rest of you, is there anything that you would like to add to Cameron's recap of what we've learned from the study and the ACEP webinar?
This is Bruce. I think Cameron did a great job summarizing kind of the highlights of the workforce study as we know it. And I think the key to highlight is there's a lot of assumptions like any modeling. And, it really is about if we did absolutely nothing at all as a specialty, kind of what would likely happen. But, there's a lot of the different variables that go into it. Any of those variables can change or be different and can really throw off the model quite a bit. So I think there is definitely hard data that we need to accept with the numbers are the numbers. And I think to Cameron's point, like any kind of specialty or organization, we have to be looking to the future to evolve, for emergency medicine. And it may be that the evolution is beyond the four walls of what we're used to.
Yeah, I agree. This is Todd, and I apologize. I'm going to be sort of in and out here. I'm working clinically, but I think, Cameron, you did a good job of summarizing it. The big challenge is going to be, really, I think, what role do emergency physicians play in the whole healthcare delivery, the healthcare system? And, we know that the value that we provide, we have to continue to show that value. I think that emergency physicians are going to need to, I'm not going to say, we're going to need to not be complacent. I think we've been fortunate for a very long time that, someone said when they were interviewing, it was not really a matter of if they could get a job. It was a matter of which job they were going to take and what location and how much money. And that was a great situation. And that may not quite be the case, but, I don't think it's a grim forecast either. I think that there's a lot of opportunity out there to really grow our specialty and prove the need for what we do. And I think that as we do that, we're going to continue to make ourselves indispensable. I think that there will be some natural movement out. If there is a bit of an oversupply, I think that there will be some physicians that maybe don't love the field as much and just want to move on to other things. And what we want to do is really continue to incentivize the young physicians that are moving up and excited about emergency medicine and are continue to grow our specialty. And we need to keep them engaged and excited about the specialty. That's what I'm going to try to focus on when I'm having private conversations with people, is to say, look, this isn't the end. This is actually a beginning, and this is a tremendous opportunity. And it's almost impossible that any specialty isn't going to face some hurdle or road bump that they have to move past and over in order to grow as a specialty. And if we embrace this, then we can do that as a specialty.
Thank you, Todd. We have a number of questions that were submitted from our attendees. I can go through them, Cameron, or if you have specific ones you want to tackle first, let me know.
No, if you want to ask them, I think that's good, and then we'll chime in. I think each of us have different perspectives we can bring to those questions.
Okay, so the first question I have is, the question is, what is being done about the influence of private equity? Why are EM residencies still expanding?
I think for some of this, the impact of private equity in physician practices, that is being looked at by VACEP. We're waiting to hear from some of the studies that they're doing about how that impacts things. And I think, it's an important discussion to be had. There's been a lot of push on a national level at council to really talk about this. And so I think that it's brought about some good discussions. How it plays into some of the residencies, I think Bruce may be able to speak a little bit more to this, but I think, what people are saying is you can't just not approve in a residency to be approved. If they meet the criteria. So I think that's where people are talking about increasing criteria, because that's where you can get some of these residency programs that seem to be funded from a for-profit hospital organization or private equity group to meet that bar that's a little bit higher. So I don't know, Bruce or Todd, if you want to talk a little bit more about that.
Well, I'll throw one thing in real quick, and I'm sure Bruce has more to say, but I think the problem of private equity funded contract and corporate groups increasing residencies is, that is a problem. But, the thing that we struggle with, and first of all, in Virginia, I'm not even aware of any, we've had increases in residencies, but I don't think any of them are actually founded by any of the private equity groups. I think that they're mostly affiliated with academic institutions. I might be wrong on that. So, but, I think it is something that we have to address and be aware of. One of the challenges that we face is that, restricting one business ownership model from doing something without restricting other sort of business ownership models, when they all sort of meet the criteria, becomes a very tricky situation. And, I work for a health system that started a residency. That residency is getting ready to start our second year. It's been a fantastic addition to our program. and our residents are outstanding. And it has nothing to do with private equity or corporate management. It has to do with the fact that we're a busy hospital and we're an ideal site for resident training. And it's helped us recruit a lot of really good attendings who are academically focused. And it's really just elevating our entire emergency medicine program. So I think that there's been this blaming, the private equity groups on the glut of residents, but that's not really the case. That's part of it. So yeah, but I don't think that's an issue in Virginia. I think in Virginia it's all academic groups that have expanded.
Yeah, so I think a couple of things to add. One is, residencies, the ACGME, which is the American College of Graduate Medical Education, they're the ones responsible for kind of the overlying body for accrediting residencies, and that's all residencies. And within each of the specialties, they'll have their own what's called RRC, Residency Review Committee. And so there's one for emergency medicine, and they set the bar in terms of what is quote unquote approved or not approved, or what's the minimum requirements to have a emergency medicine residencies. And, part of it probably goes historically, back in 2008, last time ACEP did a workforce study, at that time there was projections that there was really a huge need for many more emergency medicine doctors into the workforce. And there wasn't enough, at least at that time, from a projection standpoint. And then for a multitude of reasons, there was an increase in growth in residency programs. And in fact, it is the #1 fastest growing specialty in terms of residency positions compared to other specialties over the last several decades. And, what's interesting is give a little bit more history. In 1996, CMS essentially, they're the ones that typically fund residency positions in the United States. They had cut off the residency new funding in 96. But there's this kind of backdoor loop that, at least for new hospitals that don't have or hasn't previously had a residency program, and that's any kind of postgraduate residency program, they could apply for new residency positions at a new ACGME program at a hospital, and they would get CMS or government funding for it. And I think what a lot of people have seen, just anecdotally, is a lot of for-profit health systems like HCA has got called out specifically for this, is they have formed a lot of new different residencies across the country. And so a lot of the for-profit health systems like HCA are staffed by, CMGs or what people refer to as CMGs. And so they're, part of that is the expansion of residency programs at those types of facilities. I actually believe there is one coming up in Virginia that will be at an HCA facility that will start an emergency medicine residency program this next year that will be staffed by what we refer to as a CMG. So it's happening in Virginia. It happens in a lot of other states. Florida, and I think in particular, there's been an explosion. And part of also is the state of Florida has also encouraged and incentivized opening new residency programs as part of in their way to combat some of the doctor shortages, not just in emergency medicine, but across various specialties. So there's definitely a growing number of them at a for-profit facility. And I think there are definitely concerns about that. But it's the ACGME that really sets the bar in terms of approving or not approving. And as Todd had mentioned, it's really because they are the only accrediting body, they have a monopoly of sorts. It really is anybody that passes that bar needs to be accredited. Otherwise, it could be in violation of antitrust laws, federal laws. And so the question is, should that bar be raised? And so organizations like ACEP, I think we'll be working with the ACGME in terms of setting, what should that bar look like? And raising that bar would then definitely or potentially, slow or stop potential new residency programs from opening. So it's not within ACEP's purview to approve or not approve. It's really a different organization, the ACGME. ACEP does appoint several of those positions to the RRC within the ACGME organization for emergency medicine, but it's a different organization that approves them. So, but definitely, it's definitely expanding, and definitely, I think various people have various opinions about that. But definitely, it is an expansion, and we are or will start seeing them in Virginia here shortly.
I would add one point there, which, I think this goes back to the intent of the original question, which is, and I see this on the social media forums regarding national issues. What is ACEP doing to decrease the influence of private equity, in the practice of emergency medicine? And I think that, we are all very aware of it. In Virginia ACEP, I think we're very fortunate that, none of our board members, none of our executive folks, some people do work for CMGs, but nobody really have any sort of executive level leadership in there. And certainly in my experience, and Bruce, I would say yours, I've never seen one instance where I felt like anyone was bringing a corporate conflict of interest into the decision-making process. So one of the challenges is that if we are going to speak out and try to advocate against or rules that would prohibit some of these CMGs from doing certain things, it would be very hard to not impose the same restrictions on the Democratic groups that are in the state, because they're really both, business models of groups of physicians that contract with the hospital and employ their physicians with partners. So they really are, sort of the same entity. And so what I tell people is that, right now, in terms of at least influencing legislation and rules in the practice of emergency medicine in the state of Virginia, from a Virginia ACEP standpoint, they have very little influence. And for us to go after them would be almost inappropriate, at least based on the way things are right now.
Any other comments on this before we move on to another question? Okay, another question that we received was, do you expect emergency medicine to be more competitive for osteopathic physicians?
Yeah, I think it'll be interesting to see what happens from a med student applicant pool to emergency medicine residencies. One theory is, just like I had mentioned prior in the anesthesia world, back in the 90s, when they were facing potentially a similar situation, a lot of medical students actually chose not to go into anesthesia. And so, one question has come up is, will emergency medicine have a similar type fate? I think it's to be seen. There's a lot of moving pieces. Obviously, there is chatter on social media among the medical students about the future of emergency medicine as a career. I think one of the things that we, regardless, want to be able to encourage the bright and the best to still go into emergency medicine, because I think we still need good emergency physicians, regardless of what the workforce report shows. And part of it, though, is opening opportunities up, and how we do that, obviously, it's a multifactorial type process, but we want to make sure we're not going to discourage any kind of medical students into going into the specialty. And with the number of medical students graduating and the number of residency positions available in the U.S., as well as those, IMG international medical graduates and osteopathic students and so forth, I think there will be no shortage of students that want to enter the field. And whether osteopathic students are more likely to enter emergency medicine, I think time will just tell. It's hard to predict.
Okay. Another question we have is, what are your thoughts on the impact on emergency physician salaries?
I think, when you see supply exceed demand, the idea is that that's always going to drive down reimbursement, what physicians are being paid, because they could get someone else to do it. I think the problem with it is that it's not always clear cut. I think then, the market corrects itself in some ways. Medical students may choose not to go into it if it's not going to be worth their time. They may choose a different specialty. I think it's hard to know right now exactly what it's going to do. I think that is a big concern for early career physicians, particularly, is what is this going to do to the outlook long term for me with my income.
And I think to add to that, I think it depends on multiple factors. So we know from rural areas, there's still a lack of board certified emergency physicians working in those areas. And there's still, I think, a fair need and openings for jobs in those areas. Now, they may not be where a lot of people want to work at, but there's definitely still a demand that exists for those emergency physicians. It also will depend on your job employment type. So if you work, in a private group, for instance, and you're an owner, obviously you'll have control in terms of, how you set the structure and in terms of your reimbursement and so forth. And part of that will be, as Cameron had alluded to, how reimbursement is from insurance companies and so forth. If you're employed, that may come into effect, especially if you work in a higher desirable location where a lot of people want to work at. And unfortunately, we just don't know. However, as Cameron alluded to, basic economic principles do apply to some extent, at least, and markets tend to kind of correct themselves. So, potentially there could be a dip, but then there also could be a shortage of physicians again, just like, referring back to the anesthesiologist. Nobody wanted to go into anesthesiology, and now there's a national shortage of anesthesiologists. You just can't hire them because they just don't exist. So it'll be interesting to see what happens in the short term, what happens in the medium term, and what happens in the long term. And what history has told us is it can be very unpredictable.
And then, I would add that Cameron is a partner in a Democratic group. Bruce, you're a partner in a Democratic group. I'm an employed physician now, but I still understand the economics of that. For any physician, it doesn't matter what business model you're working in. I think understanding where and how you get paid and where that money is going and how that money is generated is important, and making yourself as economically valuable to your employer or your group is always going to help you out in the long run. I have conversations with physicians that have an impression that there's just gobs of money coming in for provider fees that are being siphoned off by various organizations, and emergency physicians are being paid pittances on that. And that's I can promise you, as a former partner in a group, and there's two other partners in groups here, all of us will say that is not the case. The margins are pretty lean, and you have to work hard to pay competitive salaries to not just your employees, but even your partners. And so, understanding the economics of it, understanding the importance of generating revenue through proper charting, and making sure that you're doing the things necessary to sort of earn your paycheck, if you will, is important. We all work hard and we all earn our paychecks, so that's probably the wrong word to use, but just understanding how that all factors in is going to be important going forward. And I think those physicians that are doing that well will continue to thrive. And so I think really the ones that are in danger are the ones that sort of take their job for granted.
And I think this really speaks to the idea, the demand side, right? What can we do to increase other opportunities for emergency physicians, and where does that expand? I think you look at the business world, and the person that always comes out ahead is the entrepreneur who expands first and gets into those new businesses. And so where we end up finding reach, with anesthesiology, it was pain management, but other opportunities, like where can we use our skills and our unique skill set to really shine. And I think there's a lot of interesting ideas. We're not just talking about urgent cares, which for some of us does not seem like a good opportunity, but really innovative ideas on getting out into communities and using our skills to solve problems. And I think that that's really where you also can balance some of that income concern. And so I think that is really something to think about and really see where we can come up with some different opportunities to have a bigger share of healthcare delivery.
I do want to add one thing to Todd's point, which is the understanding the economics of how we get paid. And I think it's one of those things from an academic standpoint. Historically, I think we could always have done a better job starting in medical school. Understanding how you get paid. Ideally, you work for a place where you can see what you get billed and what they're collecting under your name, because I think those are key things to really to understand when working in emergency medicine, and have a better appreciation. And then to Cameron's point, also to really be able to think about how to think outside the box based on the traditional things of what we do and expand that kind of business model going forward outside the four walls. And that really takes a little bit of understanding. You don't have to have an MBA or anything like that, but just having some sort of understanding basics of the money is going to be key.
Some of our attendees wanted to know about the impact of scope of practice issues on workforce concerns into the future, specifically how expanded independent practice of APPs or nurse practitioners might affect this.
I think it's a huge issue. I think, at all levels, nationwide, statewide, we've been really pushing to make sure that there are physician-led delivery models for especially emergency medicine, but really all medicine, that there's such a difference in the training gap. I am working also on this issue nationally with VACEP, and the biggest hurdle we have is that there just isn't a lot of data. And so in trying to find data that specifically speaks to quality differences of independent practice, there's just not that much out there. And so when people want to see numbers, they say, well, you train a lot longer, but does that really mean it's any better? And I think that that's really one of the biggest things that we need to push is let's get some of this data. We should be able to run chart reviews to look through some of this. We should be able to generate some differences in quality. Because we all have the anecdotal evidence that the physician-run care, you're not going to miss those big things. You're not going to order as many tests. You're not going to have as many problems as we see. So I think that really is the next big push as well. I think it's the idea now that we can say, look, that we don't need nurse practitioners to do a job a physician won't do. We have enough physicians to do these jobs. And I think that is an argument we can use in this discussion now that we have this data. Say, well, we have physicians. Somebody's going to go work there now, because that's always the argument, even though it doesn't seem to pan out that they end up working in the rural sites. So I think that is an important discussion to have. I think it's absolutely where we are going to be spending a lot of our efforts at statewide and nationally in advocating for all of the care to be physician directed.
And I would add, so this is really, and this is a state level issue. So there's some issues that are affecting emergency medicine, like the residency issue, which is really more of a national issue. But this is really a state issue because these rules and legislative issues and stuff are all going on at the state level. For those that aren't aware, in Virginia, we've sort of fought this battle for a number of years. Specifically with nurse practitioners, we're moving towards independent practice, and we had our line in the sand, which was that nurse practitioners are not a substitute for physicians. And I still remember the day that we were walking into a lot of typically very reliable legislators' offices, and the battle was lost. I mean, we quickly had to regroup and realize that nurse practitioners were likely going to get some degree of independent practice. And so we actually changed tactics very quickly and went towards a more collaborative approach, and ended up, because we got a seat at the table very quickly in terms of doing that, we were able to put in place some of the most restrictive nurse practitioner independent practice rules in the country. Actually, at the time, they were the most restrictive, with essentially creating an equivalency of a number of years of med school and residency required before you could have independent practice. And we were fortunate that we were able to do that, because the alternative was that nurse practitioners were going to get independent practice 6 months after completing their NP program. And that was what was on track to pass. So what I would say to everyone here is that as we're dealing with these types of issues legislatively, this is where volunteering and showing up matters. Responding to those emails that we send out, action alerts, to send letters and phone calls to state congressmen and senators, and just showing up in their offices when we have the white coats on call and telling our stories and having those individual stories of why physician-led teams are so important and hopefully we can sort of stop this creep. But that being said, you know, the nurse practitioner and PA lobby nationally is extraordinarily well organized and extraordinarily well funded. And we are not as well funded as they are. So it is a bit of an uphill battle from that standpoint. So, you know, the more that we can organize locally and the more volunteers, and quite frankly, the more lobbying dollars we have, then the more impact we can have to help prevent that.
One thing I'll also add is we know in other specialties, they're also facing similar issues with PAs and NPs, especially NPs moving to independent practice, especially in primary care and pediatrics. And, you know, part of it, this is kind of one rallying cry where we can kind of get together with our specialty colleagues across the streets and really kind of work to push back on this issue, because as they become more prevalent, and we see this in other states, in other specialties, we're going to see this become more and more of an issue. And I think to Todd's point, this is one of the things that requires all of us, not just a couple people, but everybody to kind of move in unison and speak as a singular voice and getting involved. And it doesn't take much time actually to get involved. And I know when I first came out, you know, I was very kind of apprehensive and scared and intimidated about going to legislators' offices and things like that. And what you realize after doing it a couple of times is actually pretty easy. And, you know, legislators actually want to hear from us, you know, the experts, because I'll tell you, the PA and NP lobbyists, for instance, that's what they're doing. They're going in full force, and we have to do the same.
And I think the other part of that is really the unified voice. So the nurses, the nurse practitioners, they're all very unified. And I think sometimes we as physicians can hash out our differences. And so it's important that we come together, whether it's whatever ACEP, AAEN, we're all emergency physicians who really care about this, and joining with the pediatricians and the family practice docs and the internal medicine docs to really kind of speak together instead of fighting out over what these, you know, minor details could mean. And so I think that's also another big important part of us coming together to lobby about this, is to really come up and show a unified voice with regards to this.
Okay, I have one more question from our registrations, and then we will open up the floor to our attendees. The question is, what do you think are the next steps for Virginia ACEP? What can our chapter do, or where should we focus our energy next with the workforce issue?
So I think first, the goal is really to listen, to hear ideas. So we've talked about what the supply side, the demand side, how do we fix this? And I don't think ACEP's really coming out with, here are our solutions. There have been a lot of ideas put out there, but really first, the goal is to really listen, because there's a lot of really innovative emergency medicine docs who figure out how to solve problems every day. And so if we can really get someone who thinks of a really unique idea, we might be able to kind of run with that and be able to come up with how a couple of these ideas work together to solve some of these problems. None of this is going to be done overnight. I think, you know, we have seen, legislatively what our priorities have been prior to coming out with the workforce stuff has been scope of practice issues. And so I think that will continue to where we focus on the scope of practice. You know, Todd talked about there's some things we can control on the state level and some things we can't. Residency approval, we really can't do a lot for. I think helping our members navigate jobs, helping our members understand the business of emergency medicine, helping our members connect on ideas on how to expand outside of a traditional emergency department. I think that's all roles that we as Virginia ACEP will play looking at this. And then we're all a part of the bigger voice. And so bringing that to national ACEP so that they then have the support to kind of really address some of the national issues, and working with SAEM and CORD and EMRA and all the other organizations really involved in this study, I think that's where our role as Virginia ACEP stands.
Any other comments on that before we open the floor?
Yeah, the only thing I'll add is to echo both Cameron and Todd is there are definitely things that maybe we have influence over. And I think the biggest thing is the PA/NP workforce, especially independent practice. I mean, absolutely within our wheelhouse. And those are state level type of issues that we want everybody to participate or as many people as possible in that issue. There are other issues such as residency approvals. That's a national issue. And so from a state chapter standpoint, we're not going to be able to influence that a whole heck of a lot. However, with that being said, to Cameron's point, I think getting everybody out there, speaking their voice, getting them involved in whichever organization, whether it's ACEP or not ACEP, there's multiple organizations that are fighting for the exact same thing, and letting your voice being heard and just getting involved. And again, it doesn't take that much to get involved. It's surprising how little effort it takes, but every little bit helps. And I think if we get many more people involved from a national front, we can move the needle, but it's going to take more than just a couple of people. So I think from a state chapter advocacy standpoint is really advocating people to getting involved both at the state level and then also at the national level.
And I think one of the other things too that's a bit of a challenge, but that we need to do are there are plenty of NPs and PAs that are advocates of our position, especially I think in the emergency, in the emergency medicine setting. I've lost track of the NPs and PAs that are like, I don't want independent practice. I'm not trained to be solo practitioner in an ER with the acuity of patients. I like the collaborative arrangement, and they like the situation that exists, and they're almost afraid that this huge push for independent practice is going to push them into situations where they're being asked to do more and more independent practice and putting themselves in situations they don't feel comfortable with. But they also say that they're afraid to speak up because there's so much pressure from their national groups and their the groups that are really pushing for the lobby. So getting as many of them as that understand that a collaborative approach is probably the best for patients to speak up is beneficial. So if you have people that work in your department that are willing to speak up and help us out, I think that will carry a lot of weight, especially with the legislature.
Thank you. I will open up the floor to our attendees. If you have a question, you can place it in the chat through the Q&A, or you can use the raise hand feature and I can turn on your audio.
I will say that some of this information, especially, I have been immersed in a lot of this for several weeks now, just trying to see what the study says, see what people are talking about. And sometimes it takes a while to really kind of process through this. So please don't hesitate that if you, sleep on it and have something come up and you want to ask questions or talk, please don't hesitate to reach out to Sarah or myself. So that we can kind of continue to have this discussion. Engaged ED, which is through ACEPs, through your membership there, and there's links on our site that you can go sign up so that there are ongoing discussions from people across the country about how to come up with solutions for this. So the emails have not been overwhelming. There were a couple of days there that you wanted to unsubscribe, but at this point, it's a good place to go and read and kind of see what other people are thinking and the pushback and sides that you may not have considered. And so I really encourage you, if you're interested in this and want to be involved, to take a look at some of that sort of stuff.
Not seeing any questions from our attendees. I think we've covered a lot of ground tonight. So I'll ask each of you if you have any closing thoughts that you'd like to share, and then we can end a little bit early.
Oh, there's a question, I think, that just popped up, Sarah. I think it was Jason Garrison. He raised it.
Can you, I can read his comment. So Jason Garrison says, nice point until the APP can practice independently, but once the door is open, their minds will change. I would approach the strategy that physicians should not sign them off to practice, with the liability rolling to the signatory, releasing the untrained/undertrained Kraken. They do not know what they do not know. Any comments on that?
No, I think any emergency physician, I mean, I would strongly discourage them from signing off on independent practice in an emergency department. I don't know anyone who would, but I'm sure there's somebody out there. But I think that policing our own and making sure that we're all on the same page is a huge portion to that. Because with the state law, they can't practice independently in emergency medicine without an ER doc signing off on them.
Any final questions before we share some closing thoughts? Give it a second. Okay, seeing none, unless some come in while you guys are talking, I'll allow each of you some time to share any additional thoughts before we end tonight.
I'll go first. I think, this is a lot to digest. I think we're all still kind of processing it ourselves. Maybe there were hints of this before, but I think, what came out is really kind of an eye opener for everybody. And I think kind of the key is as time goes on, we'll kind of see how this shakes out. Again, to Cameron's highlight, one of Cameron's points is, there's a lot of assumptions that are made into this report. However, the numbers are the numbers, and there's a certain reality that we may face based on any kind of prediction modeling that's out there. And we've seen this with, things like COVID recently and the different prediction models that exist. But I think what's definitely clear is, the numbers are there. We've seen kind of what the historic trends are. It probably makes sense that those historic trends may continue, assuming we don't do anything. And, the solutions aren't going to be easy, turnkey overnight solutions, but I think it's about staying engaged. Everybody, I would encourage them to stay educated in the topic as much as possible. I know it can be difficult sometimes on social media. I think it tends to be a lot of frustration that gets vented, which is okay. I think we all need to vent. But in there, a lot of times there are good ideas. But I think at the end of the day, it's kind of incumbent upon all of us to get involved and to advocate both for ourselves as well as for the specialty. Because I want our specialty to continue to thrive in the next 10, 20, 50 years. And what we do now is going to have a huge impact going forward. So if anything, this is just the beginning of this journey, kind of this new era that we're facing. And what I would encourage is everybody on this call, and then getting your friends also actively involved and engaged. Again, whether it's through ACEP or through any other national organization, they're all very cognizant of this exact same issue, and they're all kind of working towards solutions. And just getting involved, it doesn't take much, but definitely get involved and don't sit back and hope that somebody else will solve this problem for us.
Todd, Cameron, any last thoughts?
Yeah, I mean, I think this is not something that is completely unforeseen, which is why I think that despite assumptions made, I think we know we need to do some work to really improve our specialty and give opportunities to people who are training. We have amazing jobs that I think the majority of us really enjoy. And I think that is why medical students want to come do what we do. We fix it, right? We solve all the problems. And I think that really is where we're going to go with this. And I think I don't have as big of a gloom and doom as I think I've seen from some other people. I'm early career, I recerted for my first time, but that's it. And so I have 20, 30 years left to do this. And so as I look at that, I think there are opportunities to really make sure that we can protect our specialty, make sure that physicians lead care, make sure that we have the best and brightest coming into practice in emergency medicine. And I think that it's going to be the whole community, the whole family of emergency medicine coming together to solve these problems, to bringing new ideas, new areas of expertise that we own. And as all that happens, I think there's still going to be jobs there. I think, you know, things like COVID are going to bring up maybe a differing attrition rate. I think there's a lot to be said for what year we have just gone through. I think, you know, there could be a lot of other factors in the next 10 years that we haven't even foreseen that could affect a lot of the way we practice medicine, a lot of the way that healthcare is delivered. We do it all. And I think in general, our system expects us to be able to do it all. And if there's a problem in the hospital, they come to the ER to solve it. And that will continue. And as long as, like Todd had mentioned earlier, we continue to show the value that emergency physicians provide in developing healthcare, that will continue. And I don't see there needing to be less people who solve problems. It just may look different. And so as we continue this discussion, I really, you know, reiterate, you know, please feel free to contact me, contact Sarah, let us know your thoughts, let us know where you're concerned, and what you'd like to see Virginia ACEP do, how you'd like to be involved, what experience you can provide in looking at this. I really appreciate you guys taking your time this evening and really, you know, caring about this and the future of this specialty.
Thank you very much, Cameron, and all of our panelists. We will make this recording available on our YouTube channel shortly. And when we do, please share it with your colleagues and encourage them to reach out to us if they have any questions or ideas. My email address is Sarah, S-A-R-A-H, at VACEP, VACEP.org. Thank you all and have a good evening.